We are now moving on to the KVS NAIDU Otology session. The moderator for this session is Dr. Ravi Ramalingam, and the topic is Stapes surgery, and his panelists will be Dr. Noushad, Dr. S. Vijay Praveen, Dr. Palaniappan, Dr. Maruthi Kalyankar, and Dr. S.K.E. Appa Rao. I request all the panelists and the moderator kindly proceed towards the dais. To chair this session, I would like to call upon Dr. M.A. Rahman, Dr. K. Sudhakar Rao, and Dr. Sudha to proceed onto the stage. I repeat, Dr. Noushad, Dr. S. Vijay Praveen, Dr. Palaniappan, Dr. Maruthi Kalyankar, and Dr. S.K.E. Appa Rao to please take the chairs of the panelists. Dr. M.A. Rahman, Dr. P. Sudha, Dr. K. Sudhakar Rao to be the chairpersons for this session. AV team, please project Dr. Ravi Ramalingam's slide onto the screen.
Good afternoon. While they're getting ready, there were a couple of questions earlier about persistent stapedial artery. I had a video available, so I thought let me show to those who might be interested. That's something you don't normally see.
The timing for the session will be 1 hour. Sorry for the interruption.
Look at that. You're now operating on the left side. A routine Stapes surgery. That's the chora tympani, the incus, the facial nerve, the foot plate, and that's the suprastructure of the Stapes, a thin foot plate, and that huge structure is the persistent stapedial artery. I mean, I was lucky to see it, and lucky is a relative word, but that's how big the artery can be. And any damage to that artery could be catastrophic. So just for your orientation, it's not really part of this panel, but I wanted to show you this. So you see the foot plate is a thin foot plate, but the anterior part of it is completely covered. The Stapes actually arches over, so that runs between the crura, posterior crus stapedial tendon, arches over the crura. The artery lies below. Now, most people would have probably abandoned the operation because they're afraid, but if I was doing it now, I probably would have abandoned it, but in my younger days, this was many years ago, I went ahead and did the operation. You see, that's the artery. I drilled the posterior crus, and I removed the crus. Remove the suprastructure carefully. That was the suprastructure coming out. There you see. Anterior crus, posterior crus, removed it. And then I made a fenestra and I completed the operation. So it went on well, there was no problem, but a lot of people won't do it today. So now forget about that. That was just an interesting situation. Let's talk about the topic of today. The topic is meant to be on otosclerosis, and we have a very eminent panel. Before I even start, let me tell everybody in the panel that there are no tricks. There is nothing hidden in my questions and my slides. This is just an attempt to bring out your knowledge, bring out your practices for the benefit of the audience. So we have Dr. Praveen, Dr. Palaniappan, Dr. Maruthi, Dr. Appa Rao and Dr. Noushad, who are part of the panel. Now, an opening question. We are all experienced surgeons in the audience. I'm sure you have experience, yes. You have the best of equipment, yes. But my particular question here is, what is the instrument do you use to make the fenestra? That's a very specific question. Let's be specific out here. We have a lot to cover. We can start with Dr. Praveen. Yes. What do you use to make the fenestra, Dr. Praveen?
Sir, I use a blue laser to make a rosette on the footplate and then use a drill or skeeter to make the perforation.
So you use the skeeter with a laser. Maruthi, how about you?
I use a micromotor with a burr, diamond burr.
A diamond burr. A drill is what you use. But Appa Rao?
Usually I use perforator. If thick footplate is there, I use a quadrangular handpiece and drill.
Okay, the drill again. Noushad?
Skeeter 0.6 plus 0.8 will perforate last.
All right. And Palaniappan, how about you?
Usually perforator. In ablative, I use skeeters.
All right. So I think the point you can take from home, from all of them, is that they all have the drill available. It could be a skeeter, it could be a Ben Air, it could be a quadrangular burr, but a drill is available. I would hesitate using the manual perforators. The problem with manual perforators is that sometimes the perforator is a little blunt and you put a little too much pressure and you end up with a floating footplate. Happens often, and therefore if you have a drill, that happens less often. If you have a thick footplate, the perforator will not work. So if you're attempting Stapes surgery, please make sure that you have a drill available. It might work, the perforator might work on a thin footplate, but you definitely need a drill. To keep that, you've got a lot of options of drills available. I was pleasantly surprised. I saw at least 5 or 6 stalls outside selling skeeter or skeeter equivalents. That's something for you to think about before you start your journey on Stapes surgery. Now, we talk about radiology. In fact, in the live surgery today, it was alluded that radiology report will show us this and show us that. Let's start from this side. Palaniappan, what do you do in radiology? Do you use radiology in otosclerosis?
It is
if
my
so,
routine.
what do you do? What investigation do you do?
It's my routine. Routinely I'm taking CT.
You're taking CT scans?
CT both temporal bones.
You take a CT scan of the temporal bones. Is there anything
Temporal
particular
bones.
you ask for?
Yeah.
Anything particular you ask for?
Slice thickness.
Okay, slice thickness. Okay.
Usually.
Noushad, would you like to? We're going to keep on moving quickly.
Yeah, I never used to do for otosclerosis, but of late, last 5 years, I'm doing it. 2 reasons. Number one, I may miss something. Number medico-legally also, since I'm in a private practice, it's very important. I used to ask for a 0.5 millimeter higher resolution CT scan. And specifically, I used to write the clinical diagnosis as the radiologist to look for fistula and fenestrum, any other areas where there is spongy bone. That's the thing. To make sure that my clinical diagnosis is supporting my clinical diagnosis. Even if it is not supporting also, I may go ahead with surgery.
All right.
To avoid surprises also, we are...
So, this way, except for medico-legal purpose, the other important indication is if there is too much is bone conduction, the too much is air-bone difference, suspecting a superior semicircular dehiscency.
How many patients have you diagnosed superior canal dehiscence?
No,
I have
never. I have never, but this is an indication where...
But you have never, so what are you looking for? You'll never diagnose...
I'm looking for it, but I'm not...
All right, okay. Maruthi, how about you?
Of late, I'm going for a CT scan, but to know the thickness of the footplate particularly, or if there is dehiscence facial nerve, that gives me some idea about the...
We'll come back to you. Dr. Praveen?
Since I experienced 2 enlarged vestibular aqueduct cases, so I will always look for that and also look for cochlear otosclerosis.
All right. No, perfect. So I think you've got that got that very clearly. You may have abnormalities beyond the middle ear. You have a rare Mondini masquerading as otosclerosis. You have enlarged vestibular aqueduct. You have cochlear otosclerosis, far advanced. You could, of course, find overhanging facial nerve. You could evaluate the thickness of the footplate, where exactly the focus is. All of that could be diagnosed. Now tell me truthfully, how many of you can actually read that scan? Okay.
Yes, because after getting
I
introduced...
can't do it very well. My PG will do it for me, but that's the truth. I can't. The thing is that I can't saying let the radiologist report it. No. We should know how to read that scan properly. particularly slice thickness. I'm lucky I have a CBCT. In fact, I have 2 machines. That's a good investment to make. I've got 2 CBCT scans, get 0.5 millimeter cuts, and my PG can actually tell me the footplate is thick anteriorly, thin posteriorly. We get that much of detail. So it's important not only to get the pictures, but we should be able to read it ourselves with the data, not the film.
0.5. 0.5
the
is the
temporal
section.
bone is not enough. It has to focus on that area of the footplate,
Yes.
and that's important. Please keep that in mind.
And after getting into the field of cochlear implantation, we are looking for anomalies, and especially the vestibular duct area we are concentrating.
Point well taken.
Yeah.
Now,
Yes.
to finish off this particular slide on radiology, CT paranasal sinuses. Now you have a patient with a clear-cut otosclerosis, bilateral clear-cut patient for Stapes surgery, comes to you with sinusitis, or comes to you with a bad deviation, hypertrophy, turbinates, with some nasal symptoms. How important or relevant is that? What do you do? Let's start that side. Dr. Praveen, what do you do? Do you do a CTPNS? Do you look at the nose? Would a cold or a sniffle or frequent allergy be a factor in deciding surgery for otosclerosis?
Yes, sir, definitely. CTPNS, if it has something, the nasal pathology, I'll definitely try to address it, especially adenoids or a very gross DNS.
Adenoids unlikely, they're going to be older patients.
Yeah.
How about the nose? The patient has rhinitis, allergy, you've got some haziness. Are you going to do what? You're going to say no surgery for you? Are you going to say surgery? If so, when?
A brief medical management and reassess, and then when the TM looks normal and intact,
The
then
TM is always normal.
okay.
The TM is normal from the beginning. So now are we going to do something about the nose or proceed for surgery? I'll give you a clue, I'll proceed for surgery. So now.
Mostly after a brief medical management, then surgery, sir.
Okay, you will give medical management and then proceed. Maruthi, how about you? Any change?
Yes, if the patient is really complaining about the nasal and sinus pathology, then I can go for
He's
a
not
CT.
really complaining. You ask him, he will tell you. But nose is not the primary complaint. The ear is the primary problem.
Yes,
So, again, you'll give some medication and then think of surgery?
yes.
Yes. Any other difference of opinion out here?
No, about the CTPNS? If the
No, I mean, if you have a little hazy...
no, little hazy feeling. I don't take a CTPNS. In otosclerosis, the aim of surgery is to functional restoration.
Unless there is
of
symptoms
hearing.
on
Other than if this
sinus
is not the complaint, I will never do CTPNS or anything like that.
So, I would tend to agree with this. I have a higher threshold to go inside the nose. I'm happy to give some antihistamines and then go ahead with the ear surgery. So that's something to keep in mind. Now let's talk about surgery per se. I think Dr. Appa Rao has seen many of my slides before, so I'll ask him the question last, because he knows the answer to many of the questions. Now, would you agree that this particular patient is an ideal patient for Stapes surgery? Everybody, yes?
Why not?
Yes, so everybody is okay that this is an ideal patient for Stapes surgery. Now, now look at the airborne gap here. You've got an airborne gap of 40 dB, maybe 50 dB in this particular patient. So this is an ideal patient. How about this patient? Now, the airborne gap has changed. So the question is, starting from Palaniappan,
Yes.
what is your threshold of AB gap before you would consider surgery? Is this a patient for surgery? Is the AB gap too small? What is the ideal AB gap? What is your minimum AB gap required?
Minimum at least 20 to 40.
20 to 40. So is it 20 or is it 40?
Minimum, you ask.
Minimum
20.
AB gap of 20.
20.
Would you do surgery for 20? This is 25.
For me, I will do a speech test also in this. I will do the
Speech discrimination score.
Yeah, SDS. Speech
Okay.
discrimination score I will do. My minimum gap is 15 to 20 dB. 15 dB, if it is there, I will go and operate.
15 dB.
15.
Wow, okay. Appa Rao?
my minimum gap should be at minimum 25.
25.
Yeah.
Maruthi, how about
Maybe
you?
almost 25-30 decibel.
25, 30 decibels. And Praveen, how about you?
I would counsel the patient that post-op he might require a hearing aid, but 25 dB is my cutoff, sir.
All right, because I mean, I don't really agree with Noushad out here. 15 dB is too little.
Too little.
I think if it's a mixed loss, that really matters.
Now let's
You can make the ear aidable. You can make
this patient, okay.
Okay.
Okay. Okay, now we talk about this patient. Now you can answer the question. Look at this patient. Now you've got severe mixed hearing loss. You've got 20, 25 dB here, 20 dB, 25 dB. Now, yes, that little 20 dB is essential for the patient. Would you operate on something like this?
I will operate and I'll give the aid also.
Yeah, you will operate on this patient. You will tell the patient you need surgery, you need a hearing aid afterwards, but you will operate on this patient. Are everybody in agreement with something like this? Yes,
Yes.
Any other questions? Any
Also,
other comments?
CI might be an option, sir.
Yes, we will touch on CI.
Not this patient. Not this patient. Not this patient. It's not a patient for CA. He's got a evident airborne gap. Not
This patient might be better off if the hearing does not improve sufficiently, then maybe. But like Noushad said, this patient was still a patient for Stapes operation before a CI. Now, this is what we talked about. We've talked about this 20 dB airborne gap. So everybody said about 25 dB. So approximately this. Anything smaller than 20 dB, the perceived improvement may not be good enough. The patient may not be completely happy. Again, the same thing with this patient as well. We're going to operate on this patient, but have a hearing aid. Now, what is the youngest age that you would consider doing Stapes surgery? Let's start from that side. Dr. Praveen, what is the youngest age you would do? Patient comes to you, you don't know the history, they said the patient can't hear, that's the audiogram, that's the tympanic membrane, you're going to advise surgery, the CT scan looks normal. Now,
20 years would be my
20
earliest.
years is your time frame. So till 20 you will give a young child a hearing aid all through school, is that what you will do? Nobody likes a hearing aid, so is that what you're going to give them?
If we operate, there's further chance that again we may have to reoperate at a later age.
Okay, we will ask the next question. We'll come to.
Yeah, you are asking about the Stapes surgery, right?
Yes, we're talking about this is the finding.
It's not otosclerosis. I have my youngest age is 11 years. I have operated.
Your youngest is 11.
11 years.
Maruthi, how about you?
Most 13 to 14 years, I think. After
Why
that
do
we
you
can
have 10 to 11, 13 to 14, 20? Why are we talking about this age? Why are we talking about age being a problem here?
My patient was at a congenital fixation.
So when you have a patient, exactly, when a patient has conductive loss very early, what is the diagnosis? Are we talking about otosclerosis? Are we talking about a congenital fixation? Are we talking about some other abnormality? So we don't know the diagnosis. And also, yes, until the age of 12 or 13, they are prone to middle ear infections. And that is why the hesitation. That's when you say 10 to 14 is probably a good time. 20, you can't give a child a hearing aid for so long. Nobody wants the hearing aid. But the flip side of this, if I may add a comment, is that surgery very young has a definite higher chance of sensory neural hearing loss. So you have to keep that in the balance. So when you start worrying about SN loss, then I shouldn't be operating on them and I should be giving them a hearing aid. And that's perfect. And then you wait till 20, that's justified. But that's the fear. Some people have loss of hearing if you operate on them, and I don't know why. So that's something to keep in mind.
Yeah. Two of my patients, young children, they had an enlarged vestibular aqueduct.
Yeah,
sir.
that is the point.
That's the fear. In young
Perilymph
children,
gushes.
there is higher chance of perilymph gusher.
Perilymph gushes.
Perilymph gusher, right.
So we have to do a CT invariably for the children.
You have to do what?
CT. HRCT.
Okay. a CT
Indicated
scan.
in the case
All
of
right,
children.
So don't go in too early. I think that's probably the takeaway from this particular slide. Now, this is a common enough situation. Patient comes to you with a bilateral central perforation and bilateral symmetrical, note the word symmetrical, moderate conductive hearing loss. So that's what the patient looks like. Now, remember we're talking about otosclerosis. So the patient, you tell the patient, yes, you need to have surgery, I'll do it tomorrow morning. But the question the patient asks you is, doctor, will my hearing come back to normal? What are we going to tell them and why? Dr. Palaniappan, would you like to comment on this?
I differ.
Noushad?
Yeah, your question is, patient
If
is
I
having a
do operation tomorrow morning, am I going to guarantee good hearing?
No.
No. So
No.
why not, and what can you do?
Yeah, I will inspect the ossicular chain. If I find that the stapes is fixed, I will do the
This is
tympanoplasty
pre-op.
and come out. Pre-op.
You can't inspect the ossicular chain pre-op.
Yeah, it's a bilateral, more hearing loss is there. I expect an ossicular fixation also. So what I will do tympanoplasty. Tell the patient that getting a chance, if the perforation close, if the ossicular chain of vein is fixed, I cannot guarantee you the hearing. You may have to undergo second surgery.
So you would say you can't guarantee the hearing.
Yeah.
Is there any other way we do this, Appa Rao?
Yeah, first we have to do patch test.
I
Patch
agree.
test.
So that's what we would do.
Yeah, patch test and see observation. Then we have to tell the patient, after closing of the perforation, he may lose further hearing.
Very important.
Because we are not giving access, closing the access to the round window and all. So the further hearing loss is the caution to be given to the patient. The second stage we can do the Stapes surgery.
Right. So I think in my practice we do this quite often. The patch test is a very useful thing. We've all read that in our textbooks in early college days, and I'm not sure how many of us actually practice that. But for this particular situation, you put a patch. If the hearing improves like it has in this particular patient, you know the hearing is going to be much better. If the hearing does not improve like this, then you know the hearing is not going to improve. And like Dr. Appa Rao said, you've lost that baffle effect, if I'm right, that's the word. And the hearing may actually dip. So the patient, you may even tell him your hearing may not improve like Noushad said. But if the hearing does not improve, it's one thing. If the hearing dips another 5 decibel, even 5 or 10 decibel, then that's a major mess up because the patient is very unhappy. So for that reason, doing a patch test should be part of your armamentarium, and it's important to keep that in mind when you're doing counseling for these kinds of patients. It's just filter paper. Just any paper is fine. Now assume you talked about you will patch the patient. The patient has not improved, so it's like this. You've done surgery for this patient, and you're a great surgeon. The post-op ear looks like this. So assume post-myringoplasty. Now, does the entire panel agree that you would do a second stage Stapes on this particular patient? Yes? Everybody says yes? Everybody says yes. And can I have a comment about how long after the myringoplasty would we be talking about Stapes surgery? What is your time frame?
3 months.
3 months, 3 months, 3 months. Okay, I would personally wait longer, but let's say 3 months is fine. So
if the patient is not having any sinus pathology and all, we can interfere 3 months. If at all any mucosal pathology is there, we wait for 6 months, is worth it.
Okay, fine. So the mucosal pathology in the nose, you mean? Okay. So anyway, so we all agree that we will do a second stage Stapes operation. Now, this is a beautiful myringoplasty done by Dr. Appa Rao. Dr. Noushad has done this beautiful operation. But if I do the operation, it tends to look like this. My post-op myringoplasties tend to look like this. This is also a successful myringoplasty. The eardrum is fine, the ear is dry, the conductive loss persists. So you guys will operate on this patient for sure. What is our limit? Will we operate second stage Stapes on this patient, these patients? Will we operate? We put some cartilage in this particular case. You've got cartilage out here. You've got a little posterior-superior retraction here, defect probably. You've got maybe cartilage tympanosclerosis out here. Are we going to do second stage Stapes operation for all of these patients also?
I will go.
Dr. Noushad will operate on these, all the 3 patients. He will operate. The others in the panel?
Not the middle one, sir.
Not the middle one. You have not the middle one. I'll give you another bunch of photographs. Now how about this one? Or how about this, all these? So where do we stop saying we will not do a second stage Stapes on a patient after myringoplasty? They are all healthy years. They are all healthy. They are all fine. Do you have any comments about when you will not do second stage stapes after myringoplasty? Let's start from Palaniappan. How about you, sir?
Here I'm able to see
so
the
these are just examples.
Yeah.
I mean, they're not specific examples. Yeah. I'm asking for your general opinion. When would you say I won't operate a second stage?
See, my diagnosis in these cases are PSRP, and it is going towards incus. The stages are high. I won't do.
Okay.
Poor eustachian tube function, number one.
So this is a good eustachian tube function.
And if during the primary surgery itself, I will inspect the incus. If the incus is present, I may go.
Okay.
If it is absent, I may not, because the result of maliovestibulopexy is not as good as a ingudovestibulopexy.
Not good at all.
Yeah.
So to summarize what Noushad has said, you need to have good ventilation of the middle ear. Something like this. You look at this, it's well ventilated. Even that little retraction has well ventilated. Look, this patient may be well ventilated, may not be there, but this part is well ventilated. So you have good ventilation. And in your previous surgery, if you have an intact ossicular chain, fixed stapes, you would consider more likely than not. Is that?
And
CT,
Ravi, any retraction pathology, we have to give a caution to the patient. And as they expect stapes surgery means more than 95-96% success rate. And that is the usual phenomena.
Correct.
But in this case, be prepared to do a total foot plate removal and put a pericardium and cartilage, and other than the normal stapes piston. That would be the answer. If at all requires surgery, the first option is hearing aid. And the second option is this, caution the patient about the success outcome, or other methods of doing, not with the piston. Because the retraction pathology is there, putting a piston and retraction pathology is maybe leading to tinnitus and hearing loss and is high incidence in those situations.
I think I will disagree with one aspect of what you said. You said something about removing the foot plate, putting something on top of it. That's something I would never do. So again, to summarize and to kind of build on that.
HRCT is mandatory, no sir. If at all there is a sclerotic mastoid,
okay,
then a mastoidectomy is warranted. Post that we can do a stepidotomy.
All right. So I mean, so everybody will operate at some point of time, and they all have their limitations. Retraction is one. But uniformly as a statement, that is my comment. In my experience, and it's different for different people, second stage stapes surgery has poor results. And there is an increased risk of sudden SN loss, maybe 6 months down the line, 2 years down the line. Suddenly one day patient comes and says, I can't hear anything. This has happened to me more than a few times. Successful operation, we want the best for the patient. It's not only the patient we are worried about our reputation as well. These patients in the long term don't do as well as primary cases. So it's important take-home message to the audience. Be careful, choose your patients well. Maybe the first one, Ravi, this is a great case for...
Ravi, one more point please to be added is, if this, we have to prepare the patient for CI also. If you are prepared to go for CI after failure also, then we can attempt the surgery.
You can give a hearing aid in the first place.
No. If he is not willing to the hearing aid, if he insists for surgery, surgical outcome is not that successful, or you are going to get an implant. If then the situation comes, then we can operate.
He doesn't want a hearing aid. How will he convince him about implant?
Okay, but we have to tell in that way, angle, then he may agree. Because the longevity is increased, people are asking for us.
See, my patient will kill me if I have a dead ear. That's the problem.
Okay.
Then I say, I'll give you a cochlear implant after that. It doesn't work. So, but in general, be careful. That's all I'm trying to say.
No, medico-legally, this is a point which was raised.
Agreed.
So, unless you caution the patient for CA, there is another version of getting hearing, because the patient is not willing for hearing aid, and hearing is not that beneficial also. Then we'll go for a stapes surgery. If it all fails, then the next last resort is their CA.
Okay, so now we'll move on.
Can I add a point, sir? Cochlear implant is not the surgery of choice for primary otosclerosis. It is a surgery for far advanced otosclerosis. then there is no audible hearing. That's the indication for cochlear implant.
This is for revision surgery, Noushad. Revision cases.
Revision cases, if you have, okay, never mind, let's move on. Now, how about this one? Okay, now I'm giving you two different patients, and I will have this question. We'll talk about the patient on the left first, and we'll start with Palaniappan. You've been quiet, so we need you to be talkative as well. So, look at the left side, and would you agree or would you advise this patient Stapes surgery to improve his hearing? And what are you going to tell the patient? Is he going to be happy with Stapes surgery on the left side audiogram?
Left side.
That side, that side. The first one. The first one.
Yeah, first one.
The first one. I meant that side.
The first side.
Yeah. The first one.
This one.
What's the question?
This one.
Yeah, right side.
Okay,
Yeah.
right side.
Right,
Okay,
that's the
sorry.
right side, okay. So, yeah, it's a unilateral otosclerosis.
Unilateral.
Yeah.
You've got a high frequency loss.
Yeah.
Before I say anything else, would there be a comment? Praveen,
For
yeah.
the first one, CROS would be the choice, sir.
What will be a choice?
CROS.
CROS will be a choice, yes. Patient does not want a hearing aid. Nobody wants a hearing aid.
In that case, I will take a chance.
You will take a chance on the first side, on this side. Yes. Anybody, any other comments?
I see, it depends on total audiological evaluation, audiogram, speech recognition score, audiometric Weber, all these things along with CT scan. If I feel that it's a unilateral otosclerosis, I will go ahead with surgery.
No, I think the point I'm trying to bring out here, and now you compare with the other audiogram as well. On the first audiogram, the hearing is normal on the left side. And there is a high frequency mixed loss and a low frequency conductive loss on the right side.
Low frequency is not covering up to 2000. See,
You don't
it's
need,
up to,
you got 1.5.
yeah.
You got
That's
1.5, 1.5 is good cover. You need to, yes, but now you compare with the other patient. Both the sides are that way. So what I'm trying to say is, if I operate on the patient with a bilateral problem, he is going to be a very happy patient.
Yeah, that's what I can tell you.
Whereas the first patient is not going to be happy because it's not going to be the same as the good ear. So it's the same audiogram, it's the same level of hearing, but one patient I would definitely operate, the other patient I probably would not operate. So the point I'm trying to make to the audience is that it's not the audiogram you're treating the patient. Make sure you know what he wants. Make sure he knows what you can give him. You tell him what you can give him and you live up to that expectation. The problem comes when we promise them the moon and then finally don't deliver. That's when the problem starts. So in those days, in my earlier days, when I wanted cochlear implant patients and I wanted to do more and more, I would promise them the moon. And then I learnt my lesson quickly when I cannot live up to that promise and the patient is very unhappy. So nowadays, very clear, black and white, what can you get, what will you get, be blunt, be truthful, and that will work for you in the long term. Coming back to the topic, the patient with bilateral will be happy. The patient with unilateral, although it's the same hearing loss, is unlikely to be happy. How about this one? Talking about mixed hearing loss. Bilateral, symmetrical, mixed hearing loss. Would all of you do surgery for this patient? Yes, everybody does.
Yeah.
Yes, everybody does surgery on this patient. There is no problem. Again, it's obvious that the patient is not going to get back normal hearing. But in the most cases, the patient will get enough to hear without a hearing aid, and that's typically what they want. If they are managing with 70, 80 decibel conductive or mixed loss, and they get 30, 40 dB increase, they're going to be very happy, although they're not going to be normal. So these patients, yes, for Stapes surgery. Now this patient, what are we going to do for this patient? Hearing on the right side. This patient was initially advised, they saw me, it's a rich media tycoon in Tamil Nadu, and he wanted better hearing on the right side. So I saw him and I said, no, I cannot promise you good hearing on the right or even improvement on the right, so I refused him surgery. He wrote to the House Ear Institute, went to Los Angeles because they promised him surgery on the right side. He finally didn't have the surgery done because he wasn't convinced, and he's wearing hearing aids. But I'm just saying how advice could change. He was advised right-sided stapedectomy for that hearing loss at the House Ear Institute. How about single-sided conductive loss? Would we all operate on this kind of patient, unilateral otosclerosis? Everybody operates on this patient?
Yeah, I do.
Everybody operates on this patient. Now, the point I'm trying to highlight again for the juniors, and I know that this conference, amongst most others this time and age, is mainly with postgraduates. Do you guys, the juniors in the audience, do you know what this is? Have you ever seen this thing? Have you all seen this? If you've seen this, it means you're as old as me or older. Yes? Okay, you're old as well. The point is that not many people have it. And I actually bought this on an auction on the internet, the Baronese noise box. And it's a definite part of my armamentarium in the OPD. This is one very important thing in my OPD. And good quality tuning forks. For God's sakes, don't buy tuning forks from here. These tuning forks are bad. This 200 rupee tuning forks does not give you the kind of frequency you're looking for, and don't rely on them. Each of these tuning forks costs $150, each of them. So it's an expensive investment, but I would rely on tuning forks more than I would rely on the audiogram.
I also go with you.
Yes. Noushad, why don't you comment about that as well? About your comment about audiogram versus tuning forks.
Tuning fork, because our teacher is KVS. So, Kadu Kekda Ramalingam.
Kadu Kekda Ramalingam.
So, he was a teacher and mentor. So, tuning fork is our answer.
Me also tuning fork. I don't rely on the audiologist. The masking and everything will not be sufficient. Always tuning fork. My clinical judgment, that's the thing.
Even on the table itself, we have to do, before putting a knife, just do a tuning fork, then start the surgery.
Correct. So,
what we learned from KKR.
To illustrate that, what I've just said about the tuning fork, is that sometimes you end up with an audiogram like this, pre-operatively, you've seen the patient, wonderful, but you haven't done a Weber, so you don't know where it's lateralizing to. Sometimes when you see something like this, the audiogram could actually be something like this.
Yeah, yes.
So, profound sensory neural hearing loss masquerading as a conductive loss. This happens more often than I care to think. The audiograms that we do, even in my hospital, are sometimes wrong. So typically a patient who undergoes Stapes surgery has at least
Ravi,
2 audiograms done in the
small
hospital.
question. Can you, any bara is useful in these cases?
If you do a Weber, you'll be fine. You do
No,
tuning fork, you'll
I'm
be
talking
fine.
about bara.
I don't know. I don't ask Noushad.
Noushad?
No.
Bara?
No.
No?
No, not effective. No. See, even if the report is coming, if the audiology report is not matching with my clinical diagnosis, tuning fork test, I used to ask, repeat it. Usually profound hearing, if it is more than, the threshold is more than 80 dB, you are prone to get a conductive hearing loss on the affected side. So you should be very careful. In that matter, you have to give a should get a speech discrimination score, speech reception threshold, all these things. You have to do in a very good audiology room. Then you can go ahead with surgery.
So remember what happened if you operate on this patient, and this patient actually has a dead ear on the left side. Post-operatively, he's not going to improve, and he will have an audiometry done somewhere else, and that audiometry will look like this. So now you are responsible for converting a conductive loss to a sensory neural hearing loss, and that's your fault, although it's not your fault. So remember that, be very careful of patients with unilateral conductive loss. You need your tuning forks, you need your Baronese noise box, You need to repeat the audiogram before you touch that patient. Be careful.
Can I add a point, Ravi? In this type of patients, what I used to do is take the patient, do the test. Finally, I used to mask the normal ear with the noise sound of 100 dB, then give the hearing on this side, sensor on the side. If they're getting benefit, we can think that there is some conductive loss. That's the thing we do.
So the Baronese noise box does exactly that.
That's the thing.
Okay, so now look at this now. You've got we will start from Praveen. I've been talking, not giving you a chance to talk. Look at this particular patient. You've got left-sided otosclerosis. Patient had Stapes surgery 5 years ago, was happy for a few years, and then came with sudden loss of hearing or gradual loss of hearing. Today, the audiometry looks like this. Patient, again, like I said, nobody wants a hearing aid. So this is the situation. What would you do for this patient? What is your advice? Unilateral, right-sided, severe hearing nerve deafness, and
Yes.
left-sided conductive deafness.
I would not operate the other ear, sir.
You would not operate on the other ear, and your logic is?
Single functional ear. It's
Single functional ear, don't operate.
Don't operate.
That's been our teaching all through. Completely correct.
I will never
Maruthi,
operate.
how about you? You've been quiet.
First choice is hearing aid. And if
Okay,
patient
first choice is
insists-
hearing aid.
Yeah. Otherwise, you can go for.
So you're not going to advise surgery for the patient at the moment.
I expect that right ear had a SN loss. So first, I will give a choice to the patient. My first choice will be the hearing aid. Otherwise, if patient is, then I can go for surgery.
So Appa Rao, I'll come to you last. Palaniappan,
I won't operate.
you will not operate. Noushad?
I will not do stapedectomy in the left ear. If the patient is too stringent that he want the surgery to hear in the right ear, I may go for a cochlear implant on the right side.
Cochlear implant on the right side. That Appa Rao, now you.
I request the patient, I beg the patient to use hearing aid, otherwise I refer to Ravi.
And then I would have made you speak first itself. Anyway, the point I'm trying to make out here is that for a long time, my dad taught me that this is the only hearing ear, only good ear, don't operate on the left. But then you see more and more patients wanting to avoid a hearing aid. So then over the last few years, my thinking has changed a little bit. So now what happens, I send the patient for a hearing aid trial, not a hearing aid trial on the right side. And if the patient is benefited adequately with the hearing aid on the right side, then I've got my insurance. It's not the only good ear or only functional ear. I would operate on the left side. After all, I tom-tom saying my results for Stapes surgery are about 95-96%. So why should something go wrong on the left? So if the hearing aid is beneficial on the right side, I would offer Stapes surgery on the left. But again, like you all said, it is probably safer because the same thing could happen on the left side also. It is probably safer not to operate, but I'm giving you an alternate point of view. Now, second side Stapes, we all have agreed that we will all operate. There's nothing much in this particular slide. For the juniors, that's typically how the eardrum heals. There is a nice defect in the posterior quadrant where the bone has been cured out, and that heals nicely, well ventilated. So a well done Stapes operation typically looks like that. Now, second side. Typically what happens, patient has had surgery 10 years ago, has been very happy and says, I don't want second side, I'm very happy with one side. Fast forward 10 years. Now the patient comes to you and says, I am now willing to have the operation on the other side. Now note what has happened. The good side has also come down. So the hearing, which was good for 10 years, has now gradually deteriorated, and that's why they're coming for the other side. So the question here to the audience, starting from Palaniappan, is that would you operate on the left side now? This is the situation. Look at the audiogram.
The patient is happy for the last 10 years now.
Yes.
So I can't. I will do.
You will operate on the left side. Noushad?
I will operate.
You will operate on the left side.
Provided I will give a guarded prognosis. You don't expect a hearing compared to the right ear. That's the thing.
No, it's not even going to come near the right side. Look at this. This is the point I'm trying to highlight out here. So this is coming down. The bone conduction has come down significantly on both the sides. So you will still operate? You will operate. Yeah. It's going to come to the level of the right side. It's not going to come to normal. Yeah. The other three of you, you agree with that? You will operate on the left side? So this patient, you will operate
What is the age of the patient?
45. Okay. Now look at this one. The same thing. The right side is fine, happy for many years. Would you operate on the left side? Look at the bone conduction. The point I'm giving away, the bone conduction is lower than even the air conduction on the right side. So is this a good patient to operate on? Is the patient going to be happy? Would you operate on this patient? 25 dB airborne gap. Noushad will operate on everybody.
Yeah, not everybody. This patient I will operate.
How about the others? Appa Rao, Maruthi, Praveen, how about you?
We'll wait for some time.
If you wait, it's going to get worse, right? What's going to get better?
What is when is operated right side?
Yeah, right side operated. Right side.
No, when? Long back?
A long time, 5 years.
Then I can operate.
Then you can operate. You will operate, and you will tell the patient you will have hearing improvement, but it's not going to be close to the right side.
Yeah.
The patient is not going to be happy. 20 dB improvement and not going to be good on the other side. The patient going to be happy?
This story is always there with the second year. Always they say,
no,
first year.
This is acceptable. This is going to be fine. Look at this audiogram. This is acceptable. This one, not so much, right? The improvement is little. It's not going to be the level of the right side. Are we still willing to operate? I think the answer is yes. But we've got to remember that this is not going to be a very happy patient. Anyway, let's move on. What are the kind of prostheses that you use? I've given you enough of audiograms and bored you. Let's talk about something else. Is there a particular choice of prostheses that you use?
I use a Teflon piston, sir.
Teflon piston. And how thickness? 0.5.
0.5.
4.25
mm.
4.25 typically. The length may vary, but okay. Teflon 0.5.
Teflon 5.
Teflon.
Teflon 0.5.
Teflon 0.6 and some same tough wire also. Teflon with wire process also.
When do you use the wire processes?
When the axis of the incus and the footplate is not in the same plane, he is going under the facial now, all these things. You can just mold it little bit, angulate it and use it very nicely.
Alright, so is that the only two you have? You have a Teflon and you have a Tef wire. Is that what you have? Is there any other prosthesis that you have available with you? Malleus prosthesis. Okay, how about bucket handle? Do you have any of that? No bucket handle. Palaniappan, how about you?
Teflon. So 4.25 into 0.4.
Okay, Teflon. So now the next tricky question. Where do you get your Teflon pistons from? Start from you. Where exactly did you get it from?
Mine are from Eon Meditech, sir.
From Eon Meditech, okay.
Indian Audio Center.
Indian Audio Center. They still make it? Okay. Appa Rao?
Eon only.
Eon, okay. All Eon. Anybody use decibels? Anybody use decibels? Nobody uses. I have used a lot of decibels with no problems. I have no trouble. Yes.
The neck is not wide enough with decibel, sir. Crimping will be a bit tough with decibel.
And the decibel is a little wide, open.
The
mouth
opening
is bigger.
Yeah.
The loop is bigger. So the incus, it doesn't crimp very well.
Correct.
But otherwise, the quality of the piston,
not much difference.
I'm not sure that makes a difference to
no,
the
not much difference.
How much is an Eon prosthesis, if one of you can tell me?
250, 300, sir. Similar price only, but
250, 300 is decibel only.
No, sir. 500 if you bargain. No,
Okay.
we shouldn't take it till it up. But
6,000, 7,000?
not in thousand, sir.
Not in 1,000. Appa Rao, you?
2.5, man.
2.5. He's been cheating, you see. He's giving the same thing for 250. And he's giving you 2.5.
He's from Metro, no? They'll have the advantage.
I mean, I get my pistons from Grace Medical.
Yeah, Grace I use. Grace also I use.
Grace Medical, He's not there anyway. I mean, you bargain with him, you get it for 3,536.
Yeah, I got it once. Once
Okay.
I got it.
So I buy in bulk. I buy 200 at a time.
Don't use decibel now?
Decibel, no. Decibel, unless it's free, no. It almost always Grace, but many years I've used decibel. I've not had a problem with decibel.
Initially, we used a lot of decibel, and we purchased along with Yagyanas, initially, we
no,
bought,
that's fair enough.
and
There's nothing
gradually
I mean, we're all in the same boat.
Yeah,
we have
yeah.
the same problems.
Yeah.
So there's nothing to hide. Yes, we've used decibel. It works well. Now I've changed to Grace, and I'm happier
Yes,
with Grace.
yes, yes.
Now, what happens? You've done Stapes surgery, and the next day or after a few days, patient comes to you with one of these complaints: severe dizziness, increased tinnitus, hearing seems to have gone down. And you put the patient on steroids, you put them on Vertin, something. What else would you do? Would you open up the patient? Would you image the patient? Is there anything you would do for a patient at this stage? We'll start with Praveen, yeah.
Next day.
Next day or the next 4 or 5 days?
Yeah.
We're short time.
If the patient is not improving with stemetil injections for at least 2 days, then after 2 days, after 2 nights, I would want to re-explore,
Okay.
check for the length of the piston.
During
and
the
cut short.
operation, you struggled. There was a little floating foot plate. You struggled to take it out, so you had little struggle. Now, what are you going to expect when you open up now?
Maybe the crimping was not done properly, or
Have you actually corrected something you've done before? Ever?
I had never experienced
You never
this. Sir.
experienced. How about somebody who's done this? Have you ever?
Yeah, you see, the patient coming with the reduced hearing, initially improved, reduced hearing, with all these 2 symptoms, I may go and explore.
You
I
will
will
explore.
Yeah, maybe a leak, perilimb leak, a continuing leak, maybe
Have
there.
you ever found one?
Not yet.
You've
not
never
yet.
found one.
I-
So you never
this-
had a problem.
Yeah, I know had a
No,
problem.
but see, the reason
Ravi,
I
I'll
have
tell
never
you.
opened. I have never opened up a patient of mine.
Ravi, I'll
It's
tell
not-
you one
Sure.
patient, after 3 days, patient developed a fullness and all these symptoms.
Okay.
So once I had taken the just bandage and the cotton ball, I found it's a bulge of the tympanic membrane. The blood is collected,
Okay.
and that is produced all the symptoms. Once it is cleared, it's fine.
All
The other case, after 6 weeks, the patient developed dizziness, low dizziness, tinnitus, and hearing loss. And I explored it. I found a adhesion between the incus long process to the promontory. Maybe some adhesion because of my bone piece or bone dust or something else, and produced fibrous bands, and it is pulling, and slowly it is progressing. I explored it and I released that, and patient is fine. So this is my experience in 2 cases.
All right.
The exploration.
It's good to know, because I have never re-explored. If it's gone, is my thinking.
My point is that the audiometric Weber is still lateralized to the operated
ear.
operated ear.
You're okay.
I'm okay.
Okay. That's a good point to keep in mind, but I have never, my father taught me all this, so his practice, which I continue now, never opened it. And
Yes,
if the patient has a dead ear, so be it. I've had a few of mine. Yes, no
One
denying that.
experience, sir, when there is a thick foot plate, and if you have not saucerized it properly, and the piston won't move in and out. So, if tunneling is missed, this might happen.
In that
We
situation,
might
you have to make a
re-explore.
wide canal, wide bore.
Wide.
Correct.
So you have to make it 0.8 for
I
a
agree.
0.5 piston, because there should be gap between the edges of the piston and the
Yeah.
perforation.
That's why HRCT and Skeeter are a must.
That's a very good point. And to tell the audience, people who use the perforator and don't have a drill, and I made that point early in our discussion, they go down, make a tunnel, and then they put the piston. The piston not only is not moving properly, sometimes it's stuck. When it's stuck, in the long term, the incus gets necrosed.
Exactly.
It's not the
Because-
foot plate, it's
yes.
the
Yeah, I got it.
It's the incus which gets necrosed. So you come and see and necrose the incus. And that's because the piston is too tight. So the point is, like Appa Rao said, make a wider one.
Wider bore.
Take a bigger Skeeter drill. make it little wider. That tends to help.
In that case, the perpendicularness with the shaft of the incus, the perforation must be perpendicular. The movement should be vertical, no angulations. If at all any angulation is there because where perforation is not perpendicular to the long process of the incus, the piston will have inclination. Then it rubs against the edges.
That point is well taken when there's a thick foot plate.
Yeah, I'm talking.
When there's a thin foot plate, it doesn't matter this angle,
no,
that angle.
I'm not talking about thin.
Thick foot plate, yes.
Plate.
And should be
Wider one, wider one, and perpendicular one.
Point taken. So let's move on. We talked about this situation just now. Incus gets eroded. So you've opened up this patient. The foot plate is fixed. You've got an eroded incus. There is no lenticular process. The long process is eroded. What would you do?
Sir,
Noushad has said he's got F-wire piston available. Yeah. Is that what you use? Is that something else? Yes, anybody?
Teflon wire pistons will be ideal.
F-wire piston. And if it is shorter than this, if it is gone here.
Towards the neck, towards the body, you can trim it.
If this is gone here, you've got enough length.
And there are bucket pistons available.
Towards the body.
Bucket pistons.
Bucket will not work here. Bucket will work when you have a short incus. That's the bucket for the lenticular process. Bucket will not work. So the question is whether you put a F-wire piston or remove the incus and put a malleus to footplate assembly.
Malleus.
What is your results of hearing after malleus to footplate assembly?
Malleovestibuloplasty has not as good as the ingudovestibuloplasty.
Do you get airborne closure?
You get, yes.
You get airborne
you get airborne closure. I have done. You get airborne closure.
But if you get airborne closure, the results are the same.
Yeah, no, but as good, not as good as a ingudovestibuloplasty. That I'm telling.
So which means there is an airborne gap.
More airborne. Usual less 20 decibel, less than 20 decibel you used to get in ingudovestibuloplasty. But you may not get in all cases of malleovestibuloplasty. The reason is the angulation. The angulation of the malleus. Unless you make the malleus come posteriorly in the middle of the foot plate, that is not possible. Not possible. That is the reason.
So that's the Kurtz
prosthesis. That
prosthesis.
Yeah.
Okay. Okay. I mean, the others would agree as well. I mean, is that what you do for this?
Angulation is what hurts in MVP piston, sir. Yeah, I agree, sir.
All right, okay. So this is one thing we see often.
Ravi, what is the cause for this necrosis?
Like I said, one is tight crimping.
Okay.
Two is when the foot plate is not, sometimes you have a thick foot plate, they try to perforate it, they are not fully perforated, they put a piston which goes in but it's very tight or stuck. So here it is stuck. There is a vibration will go onto the incus, and that's where the incus tends to get necrosis.
In this case, the foot plate is intact.
This particular case, yeah, talking about when normally.
Okay.
In this particular case could be previous history of myringoplasty or previous history of CSOM causing erosion of the ossicles. It could be that.
Too tight or too little crimping, sir?
Too tight, agreed. Too little may, okay.
There's a study that the crimping gives. You shouted a moderate crimping, too tight crimping and too loose crimping. If it is too loose, if with moderate crimping, you can get a gain of 4 decibel, airborne gap closure, 4 decibel.
It can't be tight crimping.
It should not be too tight, it should be too loose.
Now, I changed over to the Eon. Eon is here, but I shouldn't say it out loud. I changed many years ago with their early days titanium prosthesis. And when I buy them in bulk. So I bought 100 titanium prosthesis at very cheap rates from them, and then I put them and I crimped them tight. Every single one of them came out. Every single one of them. So one, the tightness causes necrosis. Second, if the quality of titanium is not good, the body will extrude it out, even though it's tightly crimped. So if you're going to use titanium, wonderful, but get the Kurtz one or the Medel one, for example, and they cost 20,000-25,000 rupees per piston.
Any experience with nitinol piston, sir?
Sir?
Nitinol piston?
No, I've seen the videos, but not anymore. I mean, they came, they were a fashion at some point of time, and then they went away.
Again, this aspect, the necrosis aspect, the blood supply is from the marrow, and the inguinal artery is the antero-inferior aspect.
Correct.
And the necrosis from Posture
If you
should be-
trim too tight, sometimes
Yeah.
you're hitting it.
Yes.
Okay, so I think I'm aware of the time. I've got 2.5 minutes, so we're going to finish it quickly. This is a question about, again, the malleus to footplate assembly. This is one of patients which, sorry. Okay. So I'm just going to show you one little area. I've opened up the middle ear. And look at the incus. The incus is somewhere in front. Revision case. So look at that. The incus, I pull it. It seems too much already inside the middle ear. You pull it, it goes back. Pull it, it goes back. Now, if I put a piston and try to bring it to position and put a piston, it's going to remain a conductive loss. So what would you do for a situation like this? I'll pause the video now. I won't really talk about what I did. But you have a footplate, yes. Otosclerosis, yes. The incus is moving. It's out of position. It's not in touch with the malleus. What do you do for a situation like this? Praveen first, yeah.
MVP piston, sir.
MVP piston, right. So how about, have you got much experience with that?
Yes, I have done 2 cases, sir.
You've done 2 cases, and both those patients have got complete airborne closure?
One had a complete closure, the second part closure, sir.
Would you recommend, not recommend, I know you won't, but why not a regular Teflon piston for the audience?
We can bend it for the perfect angulation, sir.
Okay, so the MVP comes with a particular ball and socket joint, so you can bend it to get the correct angulation. If you put the regular piston, you may not have the length enough to go from the neck of the malleus all the way down to the footplate. It may be too short, the angle is not good, and the results are not good. I personally don't have experience with the MVP, but he says he's got good experience and results have been good. And now
I had to do it in a second stage, sir. Even I didn't had it in the OT.
Okay, so maybe a good idea to have one bucket handle prosthesis, a couple of TEF wire prosthesis, a titanium prosthesis, an MVP. I think we should have a little bit of a choice available to us. And most of us have only the Teflon. And that is sometimes not enough for all. Okay, I've got 5 minutes, they told me. Right, okay. So keep that in mind. How about Maruthi? Have you got experience with anything else for a situation like this?
First, I pull on the incus at its somewhat original position, and in second stage, I will try it further.
No, that's fibrosis in the malleoinferior joint. That's gone. So you pull it and leave it, it's like fibrosed, it's not going to have that movement. I've tried that.
And the MVP will the second option.
Okay. Appa Rao, have you tried?
Yeah, not that the same situation, a similar situation of come across the congenital anomalies, where we absence of stapes and conductive loss in the 15-year-old people.
Okay.
So we have done half of the footplate removal and put a vein graft and put the same incus, what is remnant is there, and overrated cartilage. The patient is absolutely fine, even almost 40 years age now. So in those days we don't have much extraordinary like pistons and all, only stapes piston. We were bound to do that similar situation, like even retraction pathology cases also, those are having autosclerosis family history. So we used to do removal of the part of the footplate, put a vein graft and put a same incus, because no other pathology is seen in that. So patients are happy with the hearing.
All right, okay. Any other comments? Okay, so I think Dr. Chowdhury gave me 5 minutes, but I'm out of slides now. So I have to finish it at this moment.
From the questions from the audience.
Are there any questions from the audience? We've got 5 minutes left now. Anything we can answer? The expert panel can answer any...
Not expert panel, the moderator has to answer first.
Madhu there, yeah.
In one of your questions you asked, post-operatively 2nd day or 5th day, tinnitus, dizziness, okay. How can patient say that my hearing is reduced?
Point well taken. The pack has to be removed.
Then you are, why you will go back and open the ear? How can patient or perceive the hearing loss? Because you have packed the external aortic canal, you have put a wick and you put a bandage. Dizziness, okay, you give steroids, giddiness, tinnitus, all is accepted. how can you say that deafness is reduced?
Madhusudan,
Yeah.
the patient perseverance regarding the conductive loss and the sensor SL loss, complete SL loss is different. When he lost the complete hearing, he'll say he is lost.
Can patient say
No
that?
doubt. No doubt.
No.
Can I add a
it's-
point? Sir,
No
can I add-
doubt.
Can I add a point?
Yeah.
I do all cases under local anesthesia, Stapes cases.
We also do.
Let me tell you, let me finish. The patient has got this thing that I used to test peroperatively. Patient say that I got a hearing. I tell the patient that I am going to close the ear with gel foam and everything. Tomorrow morning, you will start deteriorating the hearing. But if the patient, next thing is, first thing, test I will do the audiometric Weber. The patient says that I lost hearing here, I am not here able to hear, and the Weber is lateralized to the opposite ear, then that's the problem. Then that's the
Weber's is one of the most crucial point, but I don't know, we have not reopened any time.
No, I learned in Manipal. Azarika told me
Yeah.
when he'll take the tuning fork, patient says he'll always, all patients, he will do a Weber.
Yeah.
PG is operated, he will do a Weber. If it's going to the deafer ear, he is happy.
Happy.
Only when it goes to the other side, he's unhappy.
Yeah.
That's the point Noushad is making.
Yeah. Thank you.
But then, practically, patient says, I can't hear properly. I say, you come back after 4 days, you will hear well after pack removal. But that question was wrong. Agreed.
The question you have put is complete, almost complete hearing loss, the patient perseverance. It's
Correct.
different from hearing loss.
But I keep cotton and the cotton swells up.
Okay.
It gets blocked.
It's 24 hours, the cotton swells, gel foam swells, that gives 40 decibel conductive loss,
Maybe even more.
even more.
Ravi, I have a question.
Yes.
Now
of
the
course.
thing is, number of cases have come down.
Right? But number of surgeons are increased.
Number of surgeons are increasing. Was the one sure shot message to the younger generation who wants to start a surgery on the ossicles?
Don't operate, leave them all to us.
One day we are also going to leave.
Yeah.
If the juniors are not trained.
You can give, I think, yeah. He has done a lot of surgeries. My advice will be, you do regular tympanoplasty, ossiculoplasty, and Stapes should be the last surgery to be attempted. Even you can do cochlear implant surgery. And Stapes surgery, the finest surgery, you should attempt only last only, you have to attempt. And moreover that, before embarking on your Stapes surgery, you should self-assess your surgical skill very
Absolutely
well.
right, absolutely right.
Self-assess your surgical skill very judiciously.
At least-
then only start for an operation.
At least 300 to 400 micro ear surgeries should have a hand, then you attempt Stapes, then no regrets.
And then be prepared for at least 10 dead years before you are an expert. No, that's the truth. I mean, my dead years, he covered for me. But that's the truth. I mean, if somebody said, I've never had a dead year in my life, and I've done 1,000 Stapes, he's lying. That's it. He's lying. That's it.
So, most of the medical legal cases are in the post-op Stapes surgeries in ear surgery. If you take medical legal cases in India, the most of the cases belongs to post-Stapes surgery. Yes, sir.
No, I've had many dead years, never a legal case for a dead year.
Never a legal case for me. I also had out of nearly 1,000 cases, I had 3 cases, 3 dead years out of this thing. So I never had a case or anything like that.
No, medical legal. No.
So, Ravi, it is for
Thank
the
you.
juniors.
I've been,
Yeah,
been buzzing.
So,
Actually,
so we've covered up the extra time also, sir. Thank you. The discussion keeps continuing. Yes. Thank you, Dr.
so much.
Ravi, and all the
I think we've had a
panelists.
great panel discussion. Thank you for a lively discussion.
Yes, sir.
A big hand to the panel. And thank you, everybody.
Thank you,
And of
Dr.
course,
Ravi, and
Dr.
all.
Kumar Chaudhary, Dr. Appa Rao, and so many of you for having us out here. We've thoroughly enjoyed our time. Thank you again.